Thank you so much, Alfonso and Maria, for your kind introduction. I welcome you to K21, and it's another kind of endpoint, especially for those that have been at the quality of life session at 8:12. It's the other endpoint of the conference center, so I'm trying to speak about endpoints, and glad you made it to this place. It's been a difficult topic for me to prepare because talking about endpoints is, of course, a battlefield where you go into negotiations with regulators and statisticians and clinicians and so on. And it's a new field for patient advocates really to engage on discussions about endpoints and not just about pro tools and, let's say, what we expect from clinical research and so on. So I must say despite I've been in advocacy for quite a while, I had my difficulties in preparing that presentation. So also, of course, I need to, let's say, apologize if some of the things are really, let's say, looked at it from a naive point of a patient advocate and not of a medical professional, which I'm not. You see my disclosures here, and I want to talk now about, first of all, the very basic thing, because when I did research for this talk, I saw that as soon as you research about endpoints, everybody's talking about outcomes. And there's a lot of confusion, especially in the patient community, about the two things. And that's why even though that might be totally familiar to those that run trials, just some definitions. The endpoint in a clinical trial is an event, such as the occurrence of a disease, a symptom, or a particular laboratory result. So what we're measuring is whether patients meet that endpoint when they meet that endpoint. And the surrogate endpoint is a measure is not a measure in itself, is a measure in itself, and it's not the outcome that the study treatment aims to elicit. So the outcome is actually what we're trying to achieve with the treatment, and the endpoint is what we measure in the clinical trial. So, of course, measurement of that is a very interesting thing. And when we talk about this, we're very closely or very quickly getting to the point of the Holy Grail or the golden nugget, the gold standard, and so on. Because, of course, this is very decisive on whether a drug is being approved. This is very decisive on whether it's being reimbursed. And it's, of course, very crucial for us because, of course, survival is very important to us. But what I wanted to do in this introductory talk is to think about it from a patient perspective. Is it right to think about the way we handle endpoints at the moment? Is it right to think about progression-free survival? And are the priorities right if you think what is important for patients? Because we know hard endpoints like overall survival and a bit softer endpoints like progression-free survival are easy to measure. But are they really meaningful to patients? And when I did research in one of the articles, which you can see quoted here, is that we need to ask ourselves, does cancer research fall victim of what has been termed the McNamara fallacy? Measure whatever can be measured easily, disregard what cannot be measured easily, presume what cannot be measured easily is not important, or think even it doesn't exist. And that's the discussion I sometimes see when we talk about endpoints, when we talk about the non-recording of proper pro endpoints or quality of life data and so on. And of course, as a patient advocate, I must say we must measure the true endpoints of importance to patients and not something whose main advantage is to ease the measurement or to speed the trial completion or just because regulators like it best. We need to think about, is this the measure that measures what we need to find out in a disease and what we need to find out about the treatment? And of course, overall survival, I cannot argue against how easy it is to measure because there's only dead or alive. So it's very clear, it's very binary. It's something where you can make statistics and you can actually tell whether somebody still lives or not. It's easy to find out. But it takes ages to acquire the data, to actually know whether somebody's alive. And we all hope that we're no longer, like in CML today, mainly discussing about overall survival, because the overall survival is actually close to the general population of a cancer that which I have, was about 17 years ago, still a lethal disease for a large proportion of patients. So let's say if we're all successful about what we discuss here at EHA, probably overall survival in a couple of years will no longer be a topic for a lot of hematological diseases. And it's always a compound endpoint that makes things a bit more complex. So let's talk about easy measurement. But of course, it's not that usually a clinician would treat a patient with a single treatment until he dies. Usually you're trying to do multiple treatments afterwards, subsequent therapies, and side effect management and so on. And so probably just looking at overall survival is also quite composite with a couple of different things that happen in clinical practice. So what we often don't know, and it's probably because we don't do proper quality of life measurement as well, and because we quite often don't really report about subsequent therapies, careful monitoring of treatment choices post-progression should also be recorded, because then we know how overall survival was actually influenced by the decisions that were made later on when patients failed on the main treatment, on the experimental treatment. And of course we can discuss for ages, but I guess that's the story of different clinical sessions here at the Congress. This whole discussion about PFS, it's already getting quite messy in CML, because every study actually has a different definition of progression-free survival. And of course, there are hundreds of articles, and I could speak for 20 minutes about the differences there. But there's been one publication which I think is something from a patient perspective which makes a bit of sense, that if there's a short survival after progression, it's much easier to measure PFS as a surrogate for overall survival. And if there's long survival afterwards, it gets a bit more difficult. And then we really need to look at patient-relevant outcomes, such as quality of life, also in the period after progression. But again, we need to think about many studies have overall survival as primary endpoint and PFS as secondary endpoint. So is this really a patient priority, or are we missing the point by not at least putting a very different endpoint that is patient relevant as secondary endpoint to think about what we are measuring, what we are trying to find out? But again, one step back, any new treatment needs to fill two major goals: to live longer, which is overall survival, and to live better, which is the quality of survival. And how does that relate to clinical trial endpoints? We need to think about what doctors actually do when they get the approbation as a doctor. It's the Helsinki Declaration, Article 8, which says no interest can take precedence over the interest of the single research individual. And when we talk about endpoints, we need to think about, is overall survival ethical in our setting, in our disease? Because we actually need to think about what are the patient's interests, why are we doing the research, why are we exposing patients to that clinical trial, and is it justified just because regulators like it, or because there's another preference anywhere to insist on overall survival just because it's so easy to measure? And of course, the clinical trial needs to deliver meaningful and actionable clinical information. And when we talk about, we just published, I was co-author on a Lancet paper, a commission that was published at Karolinska, launched at Karolinska 3 days ago. We often don't know anything about long-term toxicities, and we don't measure side effects properly and so on. And when you talk about meaningful and actionable clinical information, there's a lot we don't record. So think about purely from a patient perspective and going away from the very technical outcome discussion is it's not just about clinical efficacy, what patients are interested in. Different patients want different things, and that's what we sometimes forget. Some patients have the preference of have a quick and hard treatment. Some want long durable remissions. Some want a longer survival. Some want maximum disease control. Some will want minimal residual disease. Some just want to reduce the symptoms, whatever the impact on overall survival will be. Some prioritize on lower side effects. Some want just better quality of life. And we had interesting sessions this morning, and again, just the last session talking about quality of life. And we're going to talk about that. Ability to work, have a social life, outpatient treatment, hospital-based care, being able to do family planning, and of course the financial impact. All these dimensions are important to patients when they decide on therapy, and that's what clinicians usually take into account, but we need to think about what does this mean on the data that we're generating in clinical trials, and how do clinical trials answer all these questions that patients can actually take a conscious choice with their doctor. And we sometimes think the patient wants that, and that's a graph from a publication that the EMA did together with Myeloma Patients Europe and Melanoma Patients Network Europe, because they wanted to find out about patient preferences and risk-benefit assessment and wanted to develop a kind of methodology to methodologically, let's say, to assess patient preferences between overall survival, very hard short-term side effects, acute side effects, and long-term chronic effects. And what you can see in this cluster graph is actually you can see different clusters. And that's what we need to do when we think about patient populations. Ask a lot of patients, and then you suddenly find out there might be a subpopulation that prefers overall survival over the other things. And there might be a population which really prefers to, let's say, hit it hard and get out of it, whatever the survival. And there might be some things at the lower end and say chronic side effects are okay, but I don't want to go through this deep shit. Patients are different, and I think what we need to do is assess that properly and not just assume what we see in clinical practice in the 8.1 minute that a patient has with its doctor to think about my 20 patients think this is, they're all for overall survival. That's why we generate data in our patient organizations to actually tell a bit about what we think is important to patients and get into that debate between clinical and patient preferences. And that's a slide that I nicked from Eric Lowe, the former executive director of Myeloma UK. We also need to think that preferences change over time. And I think myeloma is quite a good example for that, because people go from first line to second line to third line. And when they arrive at third line, they might have had already 5 different treatment regimens with probably more drugs. So we need to think about what does this mean also to endpoints. And when we look at studies which address the very late stage, very refractory patients, why do these clinical trial studies still focus mainly on PFS and OS as primary endpoints? Or are we asking the right questions in terms of their quality of life, which they have in their remaining life? So I think we need to look more holistically and also look at the course of the disease and then think about different outcomes. So again, I mean, coming back to something I presented at the beginning, do we fall victim of the McNamara fallacy? Is the unilateral focus on overall survival, sometimes PFS, just a surrogate for our failure to develop and use appropriate instruments to measure things that equally matter to patients? And I think in this session we're going to talk more about quality of life and PRO. We need to think about, do we take this enough into account, or do we just regard because we think it's not important, or disregard it because we think we cannot measure it easily, or because we think this whole debate about quality of life doesn't really exist. It exists and exists in our groups very, very heavily. So in summary, endpoints are meaningful to patients. Endpoints that are meaningful to patients might not be the same endpoints that are useful or meaningful to clinicians or regulators. Patients may find living better, like the quality of survival, of equal or even higher importance than living longer. And we need to have this debate disease by disease, stage by stage, and we need to develop proper assessments, and we need to use the methodologies that we have actually to assess that properly. What I wanted to bring across is that patients are different and preference also change during the course of a disease. We need to assess this more. Differences in symptoms and toxicity are rarely measured appropriately in clinical trials. We quite often see, to be very honest, very useless quality of life tools. And Amanda was presenting that very eloquently this morning. When you actually look at EQ5D, it doesn't have anything to do with our patient reality. It is a tool that regulators like because they can actually calculate a QALY, but it doesn't tell us anything about symptoms and side effects and patient reality. And we still, I mean, when I go in CML in discussions with sponsors of studies, I ask them, why do you use EQ5D, not a proper tool? They say, because we've used that and ICE likes it. I'm just over-exaggerating because that's probably a very simplified, let's say, message of the story. But we need to have this discussion, and probably you understand that the patient community is very ready to discuss about the use of proper tool speed, HM Pro, which Sam Salek just presented, or ERTC, QQ30, CML24, or whatever is out there. We are looking deeply into that, and we actually trained the patient advocates, which are here at the meeting, about this in our capacity building meeting at EHA just 3 days ago. And just as a final word, I mean, this is joint effort. This is something we cannot solve alone. Industry won't convince the regulators. Regulators won't listen to industry without the patients being present. And we should all work together to make a change in the endpoint discussion, because we want to survive long, but we also want to survive well. Thank you so much.